Thank you all very much. This paper has an interesting origin. As was mentioned, I've known Jim Childress since 1976, was a student of his and worked with him very closely as a graduate student when he and Tom Beecham were putting together Principles of Biomedical Ethics. There was no internet at that time, so one of my jobs was to travel around the city of Washington to libraries that I didn't know existed, finding articles of relevance for both Jim and Tom. We've known each other a long time. We've interacted at various professional meetings. And just recently, in January, Art Kaplan, who's a very good friend of mine, who now works at the NYU Medical Center, convened a group of about 20 ethicists and surgeons to discuss vascularized composite allotransplantation. And I'll explain what that is in a second. But Jim was one of the 20 or so that gathered there, and I was also. So I thought this would be an appropriate thing. In the afternoon session of that meeting, which was an all-day session, very interesting and informative, one of the sort of debates that we had was whether this is research or whether it's innovative treatment or whether it might even be standard of care at this point. And that's kind of what I'm going to be talking about in this paper. So the paper is entitled Vascular Composite Allotransplantation, or VCA, Innovative Therapy and or Research Involving Human Subjects, or even Standard of Care, SOC. Vascularized composite allotransplantation, or allograft, sometimes it's called, is described as the transplant of intact vascularized body parts, such as hands and faces. VCA also now includes arms, penises, and uteri, which have also been successfully transplanted. There are many ethical issues raised by VCA, such as informed consent of the donor or the surrogate and the recipient, issues of bodily imagery, and issues of lifelong immunosuppression therapy for a transplant that is not necessary to save a person's life. But the purpose of this study is not to discuss these ethical issues, significant as they are, but to consider whether VCA is an innovative therapy and or human subject research, or even whether it might be considered standard of care, SOC. The Belmont Report of the National Commission for the Protection of Human Subjects of Biomedical and Behavioral Research, the National Commission, contains a section entitled Boundaries Between Practice and Research. The Belmont Report is important because the spirit, if not the letter, of this document permeates what is called the common rule for research involving human subjects, 45 CFR Part 46. Federal regulations guiding and providing principles for the ethical component of research involving human subjects. This has been recently revised in a new, starting in 2018, the revisions will take place. It will be helpful to see what the National Commission says about the distinction between practice and research and apply these insights to VAC. For the most part, the term practice refers to interventions that are designed solely to enhance the well-being of an individual patient or client and that have a reasonable expectation of success. The purpose of medical or behavioral practice is to provide diagnosis, preventive treatment, or therapy to particular individuals. By contrast, the term research designates an activity designed to test an hypothesis, permit conclusions to be drawn, and thereby to develop or contribute to generalizable knowledge, expressed, for example, in theories, principles, and statements of relationships. Research is usually described in a formal protocol that sets forth an objective and a set of procedures designed to reach that objective. When a clinician departs in a significant way from standard or accepted practice, the innovation does not, in and of itself, constitute research. The fact that a procedure is experimental in the sense of new, untested, or different does not automatically place it in the category of research. Everything that I've just said comes from the Belmont Report. This section of the Belmont Report would seem to put VCA squarely into the category of practice, since VCA is an extrapolation of the considerable knowledge gained over the past 5 decades of solid organ transplantation, SOT, kidneys, livers, hearts, lungs, and among other organs, applied as a novel strategy for catastrophic loss of vital composite tissues, particularly those of the face and hands. But the Belmont Report continues its distinction between practice and research by stating, radically new procedures of this description should, however, be made the object of formal research at an early stage in order to determine whether they are safe and effective. Thus, it is the responsibility of medical practice committees, for example, to insist that a major innovation be incorporated into a formal research project. So says the Belmont Report. This statement seems to muddy the distinction between practice and research, especially when VCA is being considered, because VCA is a radically new procedure, even though based on information compiled over the decades from SOT. But how one incorporates VCA into a formal research protocol is challenging, especially since the Belmont Report describes research as an activity designed to test an hypothesis, permit conclusions to be drawn, and thereby to develop or contribute to generalizable knowledge. VCA does not and cannot conduct this activity at the present time, since the number of VCA activities is so small. Nonetheless, almost all VCA proposals have been submitted to institutional review boards, research committee review boards, for approval. I question whether IRB review is appropriate for VCA procedures, but I do not question the importance of ethical review of each procedure prior to its being performed. In 2014, Public Responsibility in Medicine and Research, PRIM&R, issued a white paper written by Alexander Capron, Hugh Tilson, and Amy Davis, entitled Health-Related Activities Along the Boundary Between Research and Practice, When to Take Alternative Approaches to Providing Ethical Oversight. This report summarizes a 3-year effort by PRIM&R to develop guidance for persons making decisions regarding the need for ethical review or oversight of health-related activities conducted along the boundary between research and practice. One of the 4 domains of health practices in which the boundary questions exist is innovative medical and surgical interventions. Since VCA is an innovative surgical intervention, this white paper is very relevant for this study. After considering issues when deciding whether formal review is needed and discussing attributes that are useful in making this decision, the paper suggests some alternate means for ethical review instead of review by an institutional review board. Since VCA is technically not research but innovative practice, reflection on this whole section might be helpful for surgeons and others involved in VCA, and is presented here. The next page or so is actually a quote from this white paper. Alternative means for ethical review. When a consideration of the factors set forth above leads to the conclusion that it would be desirable or perhaps essential for an activity in one of the 4 domains to undergo prospective ethical review, and indeed when this felt need provides the impetus for labeling the activity research, out of a sense that IRBs are the only means that are readily available to provide such review, what alternative modalities of review exist? The project participants noted that some institutions may, as a matter of convenience, ask their IRB to provide this service. In doing so, an institution must address the potential for confusion, both inside and outside the IRB, that such an assignment can create as to whether the activity receiving ethical scrutiny is research and should be judged by the standards and expectations that are relevant in reviewing research proposals. I think that is exactly what has happened with the VCA treatments since they've been generally reviewed by IRBs. It created a lot of confusion as to whether they were in fact research or innovative treatment. To continue with the PRIM&R paper, The project participants have discussed a number of modalities that have been used to provide ethical evaluation of activities along the boundary with research other than formal review by an IRB. Number one, collaborative peer review. Collaborative peer review processes can be an effective means for providing prospective scrutiny of activities that need ethical review. For example, surgeons at Boston's Children's Hospital who want to try novel procedures on patients outside a formal research protocol go through a process that involves peer review of the procedure and enhanced informed consent from the patient or surrogate decision maker. This process requires communication among surgeons, the Patient Safety Office, the IRB office, and the Hospital Ethics Committee. After a new surgical procedure has been performed a certain number of times, the surgeon must then seek approval either to adopt the procedure as clinical practice, or to structure the further evaluation of the procedure as a formal research project, which would then be subject to the usual review by an IRB. This movement from ad hoc innovation to formal evaluation under a research protocol was endorsed in the Belmont Report when the National Commission explained the concept of a boundary between medical research and practice, as I've already mentioned. Second, advisory committees. Outside of institutions such as hospital where peer review is readily available, various advisory bodies may be able to provide comparable evaluation of the ethical aspects of various activities. For example, government agencies and intergovernmental organizations, such as the World Health Organization, have empaneled scientific and technical advisory groups to review practice-based and public health activities, and a practice-based network may have a steering committee. Third, ethics consultations. Alongside formal review by the IRB, various sources of ethics consultation are available in many clinical and academic settings. Typically, such advice is sought by investigators when designing a research project that raises an unfamiliar ethical issue or when the IRB has rejected a protocol. This advice may come from someone who is formally designated ethics consultation service separate from the IRB, such as those established at a number of clinical and translation science awardee institutions, from a colleague with expertise in bioethics, or from an experienced member or staff of the IRB, either ad hoc or during regular office hours, that are provided to allow informal conversations about questions faced by investigators. Such consultations typically involve much less paperwork or formality than full IRB review, and are usually focused on ethical issues, not regulatory compliance, and are advisory rather than binding. When done correctly, ethics consultation are user-friendly and low-cost ways to provide sound advice. Fourth, colleagues and supervisors. A central consideration in this boundary-spanning domains is the need for practical, local, accessible solutions. Assuring individual education in ethical practice and continued reinforcement of personal professional responsibility for all healthcare professionals remains the backbone of ethics protections in practice settings. Fifth, guidance for self-evaluation and referral. Mechanisms that exist, those at the research boundary or of innovative practice, to triage their efforts and projects, particularly by providing explicit decision criteria rather than a comfortable but not always useful categories or labels, may be effective ways to determine whether activities require oversight. Understanding the array of organizational options for ethics review, in addition to the IRB, combined with the development of decision rules about which oversight body would be most appropriate, can substantially unburden the IRB and expedite innovation while ensuring necessary protection of the rights and welfare of the people affected. End of that long citation from the PRIM and R. I believe that the following suggestions of the white paper can clarify the status of, I believe that following the suggestions of this white paper can clarify the status of VCA procedures. Just because a procedure is prospectively reviewed by an IRB does not mean it is research subject to the common rule. In fact, there are those who would argue that the VCA is neither research nor innovative practice, but can be considered the current standard of care. These arguments are important because investigational procedures, innovative practices, are generally not covered by insurance, and more importantly, by the Department of Veterans Affairs. This is significant because many of those seeking VCA are wounded warriors who must come up with alternative funding if they are to receive an allograft. These issues are summarized nicely by the Dean and Randolph article cited above. So the bottom line comes down to money. Research, this is not research, it's innovative practice, but the government does not pay for innovative practice, and many of the people who need hands or faces or penises or arms are servicemen returning back from various war zones, and they have to find some alternate method of funding. The VA will fund aftercare, which is very significant in this area. Immunosuppression lasts for life, but they won't fund the actual research. A lot of times the researchers, because this is fairly new, pay for it themselves, or the institution pays for it, and some have gotten research grants, quote, research grants to pay for this. Challenges of reimbursement. VCA is currently considered experimental and not covered by insurers without case-by-case consideration and exception. At present, costs are borne by the performing institution, the clinicians who do the surgery and follow up at no cost, and any research grants awarded to the project. The benefits of performing a procedure under experimental status are numerous: to ensure capture of outcomes and systematic data for an emerging technique, and to ensure the procedure is done under the most carefully controlled circumstances, and so the effort is based on a research question. A limitation is that until a new procedure is proven cost-effective and reimbursed widely, availability of the procedure will be limited, representing potential barriers to access some patients may be unable to overcome. There is debate among those in the field of VCA as to when the procedure may reasonably be considered standard of care, and therefore subject to reimbursement by insurers. Some argue that hand transplantation with standard triple therapy immunosuppression, as given for solid organ transplants, should no longer be considered experimental. Two programs, the Mayo Clinic and the University of Pennsylvania, have gone so far as to establish hand transplant programs without approval of the procedure by an institutional review board. I hope that this is reviewed ethically by some board, as I've mentioned earlier, if it's not reviewed by the IRB. Any IRB approval obtained by these programs is for capturing some type of data related to the procedure, not about the procedure itself. The argument for a non-experimental stance is twofold. First, the surgical portion is essentially identical to replantation, a procedure that has been performed successfully, not considered experimental, and reimbursed successfully since the early 1960s. Secondly, the immunosuppression regimen is identical to regimens and used successfully with solid organ transplants and reimbursed for those transplants for decades. The American Society for Reconstructive Transplantation has gone so far as to develop guidelines for medical necessity determination for both hand and face transplant candidates. Proponents on the other side of the argument strongly believe that with the small numbers of VCA procedures done to date, the evidence to support its acceptance as standard of care and its cost effectiveness is lacking, and in order to continue the safe in order to ensure the safe conduct of the procedures, as well as continued data accumulation, it should remain in an experimental status. Nevertheless, some programs have negotiated with public and private insurers for coverage of post-transplant care after initial post-operative period. The negotiations occur in anticipation of transplantation as preconditions for the patient being put on the waiting list for a suitable donor. So the idea is that if they can pay for the aftercare, then the surgeons themselves or the institutions for which they work might pay for the actual transplant itself, because insurers won't pay for that. The Civilian Health and Medical Program of the Department of Veterans Affairs, CHAMPFA, is a comprehensive healthcare program in which VA shares the cost of covered healthcare services and supplies with eligible beneficiaries. The CHAMPA Policy Manual, Chapter 2, Section 16.5 is entitled Experimental/Investigational, in parentheses, Unproven Procedures. This policy specifically states that benefits are restricted to those devices, treatments, or procedures for which the safety and efficacy have been proven to be comparable to or superior to conventional therapies. Any device, medical treatment, supply, or procedure whose safety and efficacy has not been established and proven is considered experimental/investigational, parentheses, unproven, and is excluded from coverage. The policy specifically excludes hand transplant from a cadaver organ, May 2005, and organ transplant not listed as covered in the CHAMPFA policy, June 2009. None of the other VCA modalities are covered. If VCA procedures are ever to be considered the standards of care, it will be necessary for the CHAMPFA policy manual to be revised to include them. And even though good arguments can be made for considering hand transplant, at least, as standard of care, this will have to be taken up for consideration by the Department of Veterans Affairs and a change made in the CHAMPA policy manual before these surgeries will be covered by VA funds. If the policy manual is revised in the future, it is my hope that insurance companies would also consider covering hand transplant, if not all VCA procedures. Finally, it should be pointed out that in July 2013, the Secretary of Health amended the National Organ Transplant Act, NOTA, of 1986 to designate VCAs as organs. Those VCAs meeting the definition of an organ would henceforth come under the oversight of the Organ Procurement Transplantation Network, OPTN. Policies relating to this are constantly being developed and will add significant ethical oversight, I would hope, to VCAs in the future. I've described many of the challenges faced by those reformed VCAs. I hope this paper will help focus the discussion as the promise of VCAs moves forward. Thank you.